Hello everyone, this is Dr. Humanist again. Let us now study about neuromyelitis optica spectrum disorder. Okay, earlier it is called as Devick's disease. Okay, so what it is characterized by optic neuritis and myelitis. That is a inflammation of spinal cord. Okay, coming to the epidemiology, women are most commonly affected. 9:1 ratio is there in the adulthood. That is around 40 years old. It has distribution features of multiple sclerosis. Even multiple sclerosis had optic neuritis, but in NMO OSD, what happens is it's bilateral optic neuritis one with severe visual loss. In multiple sclerosis is unilateral, but not that severe. Visual loss is there, and longitudinal extensive myelitis, which means there is an involving of three or more contiguous vertebral segments, which is really in multiple. There is not continuous spinal cord involvement segments of the spinal cord. Like spotty lesions will be there in multiple sclerosis, but in this there will be contiguous, three or more contiguous vertebral segments will be involved. And unlike in multiple sclerosis, there will be progressive symptoms which are not typical in NMO. Coming to the imaging and diagnostic features, if you do MRI, there will be non-specific signal changes, like in the lesions, depending on the specific syndromes. Either it's a hypothalamic involvement is there, or if it's area prosterema, symptoms like hiccups, vomiting will be there if the area prosterema is affected. Overall, cerebral hemicells also, if they are affecting, cloud-like appearance will be there. And in spinal cord, there will be focal enhancing lesions in extending over three or more spinal cord segments. This we have to remember, three or more spinal cord segments are involved here. If you do CSF analysis, there will be pleocytosis, oligoclonal bands, which are present in multiple sclerosis also. Okay. Pathology is aquaporin 4 antibodies. Antibodies against aquaporin 4. This is the main thing you have to remember. So what will happen because of this? There will be astrocytopathy. Astrocytes will be affected. Other than that, you'll get thickened blood cell walls, demyelination, and deposition of antibody and complements. Coming to the diagnostic criteria, so either if it's, you can divide it like that. If 90% of the disease are positive for anti-aquaporin 4 antibodies, that is AQP4, IgG. Okay, so positive of that, plus at least one core clinical characteristics out of this 6. Okay, it could be optic neuritis, symptoms of visual loss, acute myelitis like spinal cord involvement, area prostrema syndrome like hiccups or nausea, vomiting, acute brain stem syndrome like dysphagia, respiratory and all symptoms, symptomatic narcolepsy or acute diencephalic syndrome. This you have to remember. And symptomatic cerebral syndrome, like cerebral hemispheres are involved. So one out of this should be positive, and positive aquaporin 4 antibodies, and exclusion of alternative diagnosis we have to do. So this is there. What if, other 10% where these antibodies are not present? For them you have to use this at least one core criteria, that is out of the 6, and plus dissemination in the space in MRI. Okay, the MRI is main thing. Okay, here MRI requirement should be there. So these are these core things. And MRI characteristics, like if optic neuritis is there, then hyperintense lesions in optic nerve. Okay, in MRI, acute myelitis, that you have to prove that more or equal to 3 contiguous segments are affected. Okay, that is there. Then area prosterema, if it is affected, then lesions in area prosterema, acute brainstem syndrome, periappendial brainstem lesions in the MRI. So these are the different MRI findings which are suggestive of NMO. So immunology and clinical course of, as I told, it has aquaporin 4 antibodies which will affect the astrocytes and paranodal regions of the nodes of Ranvier. Okay, now coming to the inflammatory markers, in the CSF we'll found what? Interleukins like interleukin 6, and one more specific astrocyte specific Lal fibrillary acidic protein, GFAP, as astrocytes have been affected here, so we'll get markedly elevated GFAP levels. Other than that, T lymphocytes you can get like Th17 type of cells. See, clinical course, coming to the, like most of the cases, there'll be recurrent course, only 10% will have monophasic. Especially those who have antibody disease, they'll follow the monophasic disease. Okay, if you don't treat the NMO, it can also lead to severe spinal cord involvement, such that if the cervical myelitis happens, there will be respiratory failure also. Okay, now coming to the associated syndromes like systemic autoimmune disorders like SLE, 40% of the cases are associated with other disorders like SLE, Sjogren, PNK associated vasculitis, myasthenia gravis, Hashimoto's, MCTD, mixed connective tissue disorders, infections like varicella zoster, Epstein-Barr virus, HIV, tuberculosis, paraneoplastic sometimes it is associated like from breast, lung, or other malignancies. Now, coming to the treatment of neuromyelitis optica, acute attacks of optic neuritis or myelitis, we have to first give high dose corticosteroids, that is methylprednisolone. That is, we can see the dosage 1 gram per day for 5 to 10 days, followed by prednisolone and taper for 2 to 3 months. Then plasma action, that is PLEX. Next is disease modifying therapies, that is mycophenolate, mycophenol mofetil 1 gram twice daily, rituximab we have to give 2 gram IV every 6 months. Combination therapy also can be used, glucocorticoids plus azathioprine. Okay, next monoclonal antibodies like eculizumab, which is anti complement protein C5, enabilizumab, that is anti CD19, that is B cell depleting, and then satralizumab, that is nothing but IL-6. Special considerations like interferon beta, glatiramer acetate, fingolimod, natalizumab, alentuzumab, which are these are drugs which are used in multiple sclerosis, are which are generally are not used here. Okay, because some in research it has shown that it is ineffective and it might worsen the NMO symptoms also. Okay, clinical course typically they are recurrent, guys, with only 10% having monophasic course. Untreated NMO, as I said, it will can lead to respiratory failures. 5-year survival rate has improved markedly with early diagnosis and effective use of immunosuppressive therapies. So this was the discussion on neuromyelitis optica spectrum disorders. Thank you.